back to Why We Nurse. I'm your host, Serena Tobar, and today we're exploring a powerful transition, moving from the bedside to the classroom. I'm joined by Karee Carter, a nurse who recently stepped into the role of clinical professor after years of hands-on experience. We'll talk about what inspired this shift, how bedside experience shapes teaching, and what it means to guide the next generation of nurses. So welcome so much, Karee. Thank you for being here. We're so excited to have you. And let's start with your nursing journey. How long were you at the bedside and what led you to consider teaching?
I've been at the bedside in healthcare for about 30 years. I started as a CNA and then was a physical therapist assistant. And after 20 years or a little more than 20 years of doing both of those total, I decided I wanted to go back and become a nurse. Back when I got into PTA school, I did get into nursing school also at that same time, but that was my backup plan. So I've been a nurse now since 2018. So I think that's about 8 years now. And what led me to teaching is I've always enjoyed teaching. Back when I was younger too, that was one of the career options for me, along with many of the other things. But as a nurse, I really enjoyed it when I had students, when I had the clinical when I was precepting the new orientees and just getting every chance I could to teach. I found I really enjoyed it. And so I was like, okay, well, maybe that's time now.
So inspiring and kind of reflective of how I got into education. Was I liked being the preceptor. I liked having those students with me. I really had a lot of inspiring professors along the way throughout my journey. And so having them be such strong mentors for me really pushed me very hard into education, because I wanted to be that strong mentor for somebody else. So I can imagine that's kind of how you're feeling, right?
Yes, exactly. I had a great preceptor, and I learned so much on how to be a nurse from her. And in nursing school, I had some really great professors. One of my first clinical instructor, I she was a retired nurse, and that was all that she did now was 1 day a week for 10 weeks each semester. She would take us to clinical, and I just really enjoyed my time with her. And I was like, you know what? That's what I want to do when I retire, just to be able to get out 1 day a week, and then I don't end up killing my husband because I have that break now that we're both retired, or in the future when we're both retired. And I was like, oh, that's what I want to do. I really loved that she was still doing that.
And it's so powerful, because these clinical professors become so much more to us. When I very first started nursing school, it was right after I had lost my son. He was 18 months old when he passed. And so starting this journey when I was already going through so much emotionally, and trying to figure out where I was very young. I was 19 years old at the time, and I just didn't even know what I wanted to do with my life, and this seemed like a good choice and a solid choice. And I had one clinical professor, Mr. Boudreau, who was doing his PhD, so he's now Dr. Boudreau, and has been Dr. Boudreau for a long time. And he was so caring and empathetic. And I remember doing the blood pressure check off, where you have the double-headed stethoscope and you've got to do the blood pressure, and then it's really high stakes and you're so nervous. And I remember he told me, he said, what are you doing in an LVN program? He said, you need to be an RN. And that really stuck with me. And I did stay in LVN for a long time, and those words just kept going over in my head. I need to do more, and I need to do more. And even beyond that, I remember we were having a meeting in his office about grades, or I don't know, I can't remember what, but I remember this. He had a Beanie Baby. Do you remember when Beanie Babies were huge? So
Yes.
this was when Beanie Babies were huge, early 2000s. And he had this Beanie Baby, and it was the same exact Beanie Baby that was buried with my son. And I just broke down in tears because seeing that Beanie Baby, it was so triggering for me. And he said, I want you to have this Beanie Baby. And so I still have that Beanie Baby because it was, he was the type of professor that was like, I know you're going through some stuff, but we're going to get you through this together. And he was like that with all of his students. And he's inspired so many students. And he had moved on and he started teaching simulation for medical students. So I just can't even imagine the hundreds, thousands of students that this one professor has impacted. And then all of the patients that those students have taken care of. This man has made such an impact on the healthcare profession just through being a teacher.
Yes, because in this role, it is such a trickle down effect because it's not just when I'm at the bedside, I'm there with the patient and their families, but that's where my impact is. Here, teaching now, or even when I'm precepting or have a student with me there, it's them plus all the families and patients that they're going to reach, plus then the preceptees that they're going to have, and then the students that they're going to have, and such. It's kind of like that chart back in health class and in school, when they in sex education.
Right.
You know, you're not having sex with just this one person. You're having sex with all the ones they've had and all the ones they've had. And this big old pyramid, that may not be appropriate here, but it is. It's just such a trickle down effect when you're in this position.
So how did you prepare for this transition? Was it emotional, exciting, a little bit of both?
Yes. It was a little bit of both. So along the last several years, I'm very involved in many aspects of nursing. I'm involved in um, our local nursing association. I was involved in many committees in the hospital that I worked at, and I took lots of opportunities to do different teaching aspects, competency checkoffs, teaching the CPR skills, like I said, students and preceptors, just pretty much anywhere I could. I had these little bits of teaching, and I ran into a, well, I'd gotten my master's in nursing education shortly after I graduated with my bachelor's because this is a second career. I'm an older student. I just felt like I had like an educational clock ticking. And so I got it pretty quickly, but I wasn't planning to use it. Like I said, this was my retirement plan. And I, it just kind of happened. There I was there at a meeting and I was beginning to feel like I needed to do something different. I wasn't quite sure what it was. And I really liked my unit. I worked on a very unique unit, and I knew I wasn't going to be able to find that same uniqueness anywhere else. I was pretty much going to have to choose one path or another if I stayed at the bedside. We were at a meeting, and our CNO was talking about some plans for our system and some education plans, and that popped my head up. And I was like, wow, okay, that's what I want to do. And so I told my director, and a friend of mine from college had been working at the school that I'm at now, and she'd been asking me to come aboard. When am I going to come aboard? When am I going to come aboard? And I did a semester as an adjunct, and just hearing her talking about the plans for the system and such for me, it's just what cemented that now's the time for that. I still love the bedside. I miss the bedside. I think probably if I could find a perfect balance, it would still be like a day or two a week at the bedside and 2 or 3 days a week teaching or something like that. If I could find that opportunity prior to get to teaching full time now, I wouldn't leave now for this. But I think if I could have found that, it was. So yes, it was scary. Change is always scary and exciting and all of the things, all the feelings. So it was emotional because I was like, am I doing the right thing? I still love the bedside. Is this the time? Because too, I was like, I've been on the same unit the entire time I was a nurse. I do have things that I can certainly teach the students, but I felt like, I wanted different hospital systems so I could have that opportunities or experiences to bring to the students. I wanted to work in different units. I wanted, an ICU, ER, OR, something like that, so I could bring those experiences to the students and knowledge and stuff. And I didn't, but I don't know. It was time, and I, I'm glad I made the jump.
And speaking of what you were talking about, if you could have been at the bedside for a few days and then teaching other, they are starting to have these models out there where bedside nurses can do, their 3 shifts, and then it's partnerships with different universities and colleges. So they do their 3 shifts, and then they could do a 4th shift as a clinical instructor on their in their hospital that they work at. And so somehow there's some funding. I'm not sure if it's grant funding or if it's like, the school pays 50% and the hospital's paying 50%, but there's money there for them to be able to do this. And I think this is so neat. It is such a neat way to get more clinical instructors, because that's where schools are always struggling.
Yes.
They might have a clinical placement, but they don't have an instructor for that placement. Or they're having to do shifts that they can't get covered by an instructor. It's really hard to get night shifts covered by a clinical instructor,
Right.
especially if you have to teach didactic during the day.
Yes.
So
Yes.
this is such a great program that they've come up with. And
It is, and they even have some even have the programs where, so instead of the nurse working the 4th shift, they do it during clinical times for whatever school it's associated with. They do 2 shifts at the bedside and then 1 shift as a clinical instructor. So they're still only working their 3 days because, of course, that's one of the attractions of nursing is your 3 12s, and then you're off the rest of the time. So during clinical time, it's still just 3 shifts, but one of them is as an instructor. And then whenever the school's off and you're still full time and you're getting paid your same rate and everything. And then whenever the school is off and not in clinical, then you're doing 3 shifts at the bedside. So that that is good. We're working on trying to look at something for our program with that.
yes, and you brought up a good point. They get paid their rate.
Yes.
Because unfortunately, schools just don't have the money to pay hospital rate for clinical instructors. And so to be a clinical instructor, especially if you're going to do it full time, you're essentially taking a pay cut. And not everybody is in a place in their life where they can take a pay cut. Some
Yes.
people can. They may have, the stability. It may work better for their work life balance, but not everybody can do that. And so it is a really attractive way to bring in extra clinical instructors, because I may do it if I'm going to make my bedside rate
Right.
being a clinical instructor. But if I've got to take a $10 pay cut on that extra shift or that clinical shift, then that's not as attractive to me, right? So
Yeah. And
these are
then,
great
yeah, and then
programs.
you're working, 4 or 5 12s because you're picking up, your 3 shifts at bedside and then 1 or 2 clinical shifts or something. That gets to be a lot also.
Right. Right. It's got to be that work life balance for sure.
Yes.
And that's different for everybody.
Exactly. Exactly.
So, what's it like teaching these students who are just starting out? How do you bring that bedside experience into the classroom?
Lots of stories. I love the stories that my professors used to tell, and it seems like they like the stories also. And they're not all my stories. Some are stories I have, obviously have a lot of nurse friends, and so some are stories that they've told me, some are stories that I've seen and heard on social media or in the news and such, and I don't ever claim that they're mine, but also it's not necessarily that I'm telling them also, well, this one time I had a patient or whatever. I just make up a Mr. Smith in room 3 is, and then whatever the scenario is that we're working on. And, but just bringing those stories and trying to bring everything to life. I will tell you another scary part though is too that as it's been told to me several times, well, you're the smartest person in the room right now. You're the expert. You know more than they do. And I'm like, that's pretty scary then so far. I just taught a section on the endocrine system. I don't know anything about that. So I'm having to go through and use a lot of the same books that I used in nursing school, of course, updated editions, but I'm like, I'm in nursing school all over again too, because I'm having to read these same chapters that they're reading while I'm preparing for the lecture, because I want to be able to answer their questions or, be able to tell them correctly, of course. And so, yeah, just lots of lots of stories and letting them know that it's okay. We may not know, but we'll find it out together.
Right. And that's what you can bring. So, like you said, you may not have worked on an endocrine floor where you know the ins and the outs of the endocrine system, but you have that fundamental base knowledge and you know where to find it and you know how to apply that knowledge. And that's how you help your students, right? Because just starting out, they don't know where to look. They don't know what's real versus what's not. And what I mean by that is, like, what is peer reviewed? What is the source of truth versus, like you mentioned earlier, social media. There's so much misinformation, disinformation out there. And so it takes time to really cultivate that sense of knowing, okay, this is a source of truth where you're kind of stretching it there, right? You're kind of pulling half truths and really not getting the whole story. So somebody who doesn't know how to discern that, it can be very misleading.
Yes. And I try like I can tell myself in myself whenever I am lecturing right now, and I haven't been lecturing very long because of course we just started class the middle of August, and so I spent a few weeks watching some of the other professors lecture, and I can tell myself when the difference in my lecture, like my endocrine lecture versus my ostomy lecture, I can tell a huge difference in it because ostomies I'm much more comfortable with. And the information of it, I'm much more comfortable with that versus, like I said, the endocrine. We have a neuro section coming up. I'm hoping I should be pretty good with that one too because I worked on a neuro unit. So definitely can feel the difference in myself.
What's one lesson or mindset that you try to instill into all of your students?
I think there's two. And the first one, and I tell this to all the new employees that I precepted, to the students that I had even when I was on the unit, because it happened to me, is that number one, you're human and you're going to make mistakes, and it's okay. And when you do make those mistakes, though, you need to own it. You have a reason why you made it. Sometimes you're pulling the reason out your ear, but you have a reason why you made the mistake, and then you learn from it and do better next time. And like I said, I've had that experience myself that something's happened. I've had to make that phone call to the doctor. Hey, I messed up here. This is what happened. This is why. Or maybe it's not even something that I really messed up with. It was the way the orders were, and I looked at all the things and still, like, it was a patient who had ended up having some low blood pressures later in the day, and I had given the blood pressure medicine, and I looked at the trends of the blood pressure, and okay, well, when I call the doctors later, they're like, why'd you give them the blood pressure medicine? Don't give it if it's, and they give me parameters then. I'm like, well, they still would have gotten the blood pressure because, again, the blood pressure was higher than the parameters that you're giving me now. And I looked at the trends. So I had my reasoning as to why I did it. But then I've also learned from that, maybe I'm not going to give all these blood pressure medicines at one time, even if the blood pressure is okay, we're going to spread them out. And then the other thing that I teach them is, or try to put into them, is that you want to make sure you're looking at the whole picture, that you're using your critical thinking and you're looking you're looking at the whole picture. Like I said with my blood pressure guy example, there is, I looked at the trends. I looked at when he'd been getting these medications, what his blood pressure has been doing, because that lab result, that vital signs, that's all just a moment in time. It's the lab results are what the blood is doing right then when they took the blood. The vital signs is what the vital signs are right then when they took those vital signs. You have to see how it's affecting the patient and then put that big picture together. And how does, so if I give them this, how is that going to affect them, or how has that been affecting them, by looking at your trends? So those are, I think, the two things that I really try to instill in them. You're human, and look at the big picture.
And I think those are very important because, again, we've talked about this a couple of times on the podcast. You know, you hit those moments where you really get that imposter syndrome. You really feel like, I don't know what I'm doing. Am I really meant to be a nurse? And being able to give yourself that grace and say, I'm human, I'm learning, I'm growing, right? But also having enough knowledge instilled to you to say, hold on, let me pause, let me look at the bigger picture before I make a mistake that can't be fixed, right? Because it's okay to make a mistake that can be fixed, but sometimes we have to really make sure that we give ourselves enough pause to say, let me see what's going on, let me look at this bigger picture. And we always tell them, you know, we have to treat the patient, not the machine, right?
Correct.
Because the
Yes.
machine might be wrong.
Yes. Yeah, if that's that one off, that that blood pressure is awfully low and things haven't, then okay, we're gonna take it again. Or again, just recently I had one, the aide took the blood pressure and comes back and tells me, oh, her blood pressure is like 200 and something over 100 and something. And I was right outside the room, and granted, all I did was kind of peek in because I've been with the patient all day. And I also know that she just had an incident where she had eaten a piece of dry chicken and had a coughing fit. Don't know that she was exactly choking, but she felt that she was choking. But she just had a coughing fit, and the anxiety of, I feel like I'm choking and such like this. And so I'm like, let's give her a minute, go take some other blood pressures, and come back and recheck it. And sure enough, let her have that time to calm down. So just knowing that instead of just rushing in and, oh my gosh, and okay, now we got to call a rapid and we got to get the neurologist on the phone because she's probably having a stroke because her blood pressure is so high. And no, we're going to look at the big picture. We have to assess the patient. So yes, like you said, that one off there, it's a little bit, but yeah, definitely taking the time to look at the whole patient and not treat the machine, what's going on.
What's been that biggest challenge moving from clinical practice to academia?
I think again, it's been I have no idea what I'm doing. I don't know anything about Addison's disease and Cushing's disease other than what I learned 8 years or so ago back in nursing school. um, and that's been my challenge. And a big part of it is my personality because I want to be good. I want to know what I'm doing. I want to, make sure that I don't feel like a fool or an idiot when I'm up in front of them lecturing. And so that's, I think, been my biggest challenge, is giving myself the grace that I tell them to give themselves. And but the lecturing part, and just, I'm talking in front of people often and all the time, but up there and having, I think I got about 40 kids in my main class, or 40 adults. I call them kids, but some of them are my age too. They're all kids to me. But I got 40 people staring back at me, just waiting for me to pour the information into them. And, oh, what is she going to say? And, so it's, oh, what am I going to say? Am I going to know this? And of course, they're all thinking, oh, what do I need to know? And how is this going to affect me? And, oh my God. So that's, yeah.
Yeah,
That's been the hardest part.
you've kind of had to move from expert back to novice. And I like how you said giving yourself the grace, because you're also learning and growing in this
Yeah.
new role where you're now a novice again.
Yes. Yes. And yeah, that's been very, very scary. And as I'm, making these PowerPoints and just learning so much, because there is a lot to it, that not only am I learning how to be a full-time educator where I'm up in front of them and I'm lecturing and teaching them, but I'm also having to make the PowerPoints. And I don't have to make them from scratch, of course, but I'm having to learn PowerPoint stuff because I want the slides to be interesting too, and not just, black and white and a bunch of words, because I remember having that, and making them interesting in that I don't want to just be up there reading the PowerPoint to them. So, so many novice things that I'm having to do now, putting that together, making tests, things that I just never even thought of before. It was like, here's your test, and didn't think of or realize how much work actually goes into making the tests for the students.
It's a lot of work. So, how do you stay connected to the realities of bedside nursing while you're teaching?
Well, I still work some. I don't work regularly. Right now, it's where I'm at, I have to do 3 shifts within a 6 week period. And that's pretty much what I've been doing right now because I'm learning in this other role and just other life things that are going on. But December, I'm off most of December, so I'm hoping to pick up some more shifts then. But staying connected there, doing the bedside stuff, and still staying up with the associations and reading some of the different articles and journals that come across on the different social medias as they pop up and they pertain, and oh, that's kind of interesting, and finding out the new information there.
Yeah, it's very important to really, be a part of those professional organizations. But not only that, but staying abreast of the latest evidence, right? Because that's what our hospitals are doing. They're going through, they're looking at the articles, and they're saying, "Oh, this is the newest evidence." Going to conferences, they're saying, "Oh, this is what's working now." Because, as you and I both know, we've been around healthcare for a very long time, and it's nothing like what it was when we first started. There's been so much new evidence and things that we used to do that we thought were must-dos. You had to do them. It was the only way to do it. We have learned that maybe we don't really need to do that. Maybe there's a better way, and there is a better way. And so we have really grown and evolved as a profession through research and evidence-based practice and quality improvement, and constantly re-looking at that. So very good point, that in the education realm, you still have to stay abreast of all of that so that when your students come out, they're very prepared for what is current practice,
Yes.
and not something that's antiquated.
Right, because being there, and that's one of the things I think that happens with a lot of professors, and it may at some point happen to me also, I don't know, but is they are so far removed from the bedside, kind of like a lot of administrators, because they get to that role and then they're not at the bedside anymore. So they don't have the news stories, or they don't have experiences that they can bring back to tell the students to really help cement it. Because when you can take a real life experience that you've had and you're teaching the students about taking blood pressures or reading labs, and then you can tell them, well, just not too long ago I had a patient whose potassium was 2.9, and this is what I saw, and this is what clued me in that maybe we need to check ourselves, but you can really bring it to life for them, and that helps a lot with understanding and putting the big picture together like we talked about earlier. And then nursing and medicine in general, that's why they call it a practice too, because it's ever evolving, ever changing, and growing and improving. So but definitely staying there at the bedside helps.
Yes. What advice would you give nurses who are thinking about becoming educators?
Take those little opportunities anytime you can if it's something that you truly would like to do. Like I said, I started with the becoming a CPR instructor at the hospital. I Our competencies that we have to do, I think once or twice a year. I would pick up shifts to be one of the stations there, and that always includes a little bit of teaching. I was at another nursing school different than the one I'm at now, where I just worked in the lab. I picked up shifts as an adjunct professor in the lab doing some checkoffs there. Become a clinical instructor. That's 1 day a week for 5 to 10 weeks, depending on what school you're at. And and then it's only 1 to 3 times a year, again, depending on what school you're at. And you have those little moments of teaching to kind of dip your toes in the water to see, is this something that I'm interested in? Is this something that I really want to do? But having those little moments, picking up adjunct shifts in the lab at your local nursing school, where you come in again and maybe you're running a simulation or you're doing checkoffs or just helping around there. I had even offered to do some guest lectures. That part never came to fruition for me, but or even getting with your association or your whatever your specialty or your state association and try to do some teaching for the NCPD hours that we have to have. You can develop a course, or maybe kind of like for me, someone who's retiring and they have a course developed, and you can pick it up because it's still information that's needed. So just finding those opportunities to do any teaching that you can, develop any type of course. Maybe if you're a charge nurse, I know that was one of the things that I was looking at for my system too, is I was going to start teaching charge nurse classes or helping to teach with the charge nurse classes. Just could never get it lined up in our schedules, and then this opportunity came. But that would be my advice, is just picking up any of the teaching opportunities that you can.
I agree with that. I think one thing I've heard, and it kind of stuck with me and resonated with me, is, you know, we tend to think that when our leadership asks us to do something or whatever, it's like, oh, you're asking me to do something else. I don't get paid extra for this. Well, God, they just want me to do extra things. But that's not always the case. Sometimes when your leadership, your management, they're asking you, hey, can you be, the teacher of the charge nurse class? Can you help with these competency checkoffs? It's because they see something in you and they are really trying to develop you to the next level. And so sometimes we tend to cut off our nose to spite our own face just because we are such in a negative mindset that we can't turn that around and see they're really trying to grow us, right? And if my goal is to be a manager or be an educator or be, something else, right? Be an advanced practice nurse, a nurse practitioner. These are opportunities that I can put on my resume that are going to grow me, that are going to get me to where my professional goals are. And sometimes we just shut those doors before they can even have the opportunity to open fully. So that is wonderful, very sound advice that you've given. So how has this transition changed your view of nursing and your impact on the profession?
I don't know that it's changed my view of nursing as much as possibly changed my impact, I guess you could say. And just because, like I was telling my friend who is now my boss, that I'm really, one of the things I'm really excited about this is how it's going to make me a better nurse. Because again, I'm having, like I said earlier, I'm having to go back and relearn all that stuff that I learned in nursing school that I didn't get to put into practice much. So I'm having to review the side effects of medications. I'm having to review these different labs. I'm having to review these different systems, these different disease processes. And I can only imagine that that would just continue to make me an even better nurse, because it's now fresh in my mind again. And so maybe I'm going to be able to pick up on something with a patient that in the past may have taken me longer to pick up on it because I wasn't looking for it, because it's just way back. I always say, it's filed back there somewhere, and at some point I'll pull it up, but it was filed way back there. And so it's kind of moving its way forward because I'm having to teach the students again. So just reviewing and renewing my hope, I guess, for the profession too, for what's to come.
I mean, I think that's very impactful. You know, renewing your faith in our profession, impact that we have.
Yes, and just again, like I said, the renewing of this information again, because you tend to get into if you're an ICU nurse, I would assume that um, your NCPD hours are probably more ICU related. So maybe it's how does this new machine work, or renewing how to use or take care of a patient who's on an LVAD or something, because maybe you don't get that a whole too much. So you want to renew that, and so you kind of get pigeonholed a little bit. I work. My specialty is ortho, neuro, and inpatient rehab. So a lot of the information that I took focused on those things. But yet I can't get floated anywhere in the hospital, and I'm still going to have to take care of other patients who don't fall into one of those three categories. So definitely broadening all of our scopes, I think, is always a good thing. Don't just because you're an ICU nurse doesn't mean you can't go take a med surge continuing education course or something to help remind, or where your patient's going to also.
Yeah. No, I mean that's very good advice because yeah, you're right. You get into your specialty, you specialize, you get certified. Your certification requires, 30, 40 hours of continuing nursing professional development within that specialty. And so that's way more than what you need to renew your license. So you've got your hours there. And then once you've done the requirements from the Board of the Nursing and add that on, you're kind of continuing education out, right? So you're not always, ready to go do something that's outside of your specialty. But it can be very, important, right? Because even our acute care non-ICU areas, they can be very specialized, right? So we tend to throw med surge out there. Med surge is a specialty all of its own. But within your acute care, quote, med surge areas, you may have a unit that really focuses on neuro and rehabilitation. You may have a unit that really focuses on like liver disorders. You may have a unit that really focuses on respiratory. So you're spending all your time really kind of focusing on those things because that's the patient population that you take care of. But again, they fall under this large umbrella of med-surg, and you could float from one area to another. And so it would behoove you to really take some time and learn about that heart failure patient, or learn about that 89-year-old geriatric patient that you might have to take care of one day. Learn about that cystic fibrosis patient and expand that knowledge, right? Open those files up a little bit.
Yes, exactly. Because then you never know what you're going to be taking care of. Because just because you're an ICU nurse, though, your patient, like I saw somebody on social media the other day that, once those checks go from Q1 to Q4, off to the floor you go. Or, if I have to ambulate you, off to the floor you go. Because we can't do Q1 hour checks on med surg units. I mean, we don't have that capacity. So that is an ICU patient, and our checks are more Q4 hours. And but at the same time, I may have a patient that I have to do some of those things on because there's not an ICU bed available. I'm not ICU trained, but I have to know how to take care of this patient in this moment until an ICU bed becomes available, and vice versa though too. There may not be a floor bed available to get the patient out of ICU, so they're gonna stay there in ICU. So now you need to know how to switch that mindset thinking, and like I said, be able to prepare your patient for going one way or the other, either from med surge to critical or critical to med surge. So yeah, definitely broadening our scopes.
Yes. So Karee, let's leave our guests with this last little bit of advice that you have. And I want to know, what do you hope that your students carry with them into their careers?
I hope that they carry, like I talked about earlier, that I'm human and mistakes will be made, but hopefully I'm looking at the big enough picture that, like you said earlier too, it's a mistake that can still be corrected or a mistake that the person will survive. Because many of us nurses are familiar with the mistake that was made in we're in Vanderbilt a few years ago, and that one couldn't be reversed. And I've heard her speak several times, and there's things that she did correctly and things that I'm still thinking as a nurse, how did you not do these other things? But just knowing and taking with them to take that time to give yourself the grace, take the time to stop for a minute, even as busy as you are, there's always a minute to stop, just take a breath, refocus, let the phone ring. That's okay, because my phone will ring and my patients will tell me several times, they're like, "Oh, your phone, somebody's really trying to get in touch with you." But I'm like, you know what? I'm here with you right now, and this is where I need to be. So just taking that moment to let the phone ring, it's okay, and you know, but just critical think, look at the big picture, and give yourself the grace. And hopefully that they think I was a good instructor also, and I've impacted them somehow.
Give you good ratings on Rate My Professor.
Fingers crossed, fingers crossed.
Thank you so much, Karee, for being here with us today.
Of course.
Um,
It's so
Teaching
fun.
is more than instruction, it's legacy. And hearing Karee's story reminds us that every nurse has the power to shape the future of healthcare, not just through care, but through mentorship. Whether you're at the bedside or the front of the classroom, your voice matters, your story matters, and that's why we nurse. Thanks for joining me for this episode of Why We Nurse. If you found this conversation inspiring, share it with a fellow nurse or educator. Follow us at Why We Nurse on Instagram for updates and behind the scenes content. Got a story to share or want to be a guest? Email me at whywenursepodcast@gmail.com. Until next time, stay strong, stay compassionate, and remember why you nurse.